Okay, hello everyone. Welcome to the first affiliated hospital of Harbin Medical University again. I am Dr. Cao Yang from Cardiovascular Department. I am privileged to be the moderator of the current operation through MedStream 360 to demonstrate our theory and techniques in our daily PCI work. I hope each and every one of you will enjoy the following unique calcified case. Next, please allow me to introduce the leading operator of today, Professor Li. And also that we are familiar with Professor Li, who is a high volume and a very experienced PCI operator. Today, we are going to face a very unique calcified case. And next, Dr. Dong will introduce the general information of this case. Please, Dr. Dong.
Okay, thank you. Hello, everybody. I'm glad to have this opportunity to introduce this case. First of all, let me introduce the operator. The first operator of this case is Professor Li Yue, and the second operator, Wang Dingyu, Shi Zhiyu, and me. The moderator of this case is Professor Cao Yang. Next. And this patient is 64 years old male and suffer from chest pain for 3 months. And the risk factor are hypertension for 10 years, diameters for 10 years. The injection fraction is 60%. Next. Laboratory data, we can see glucose and BNP a little bit higher, and others are almost normal. Next. Electrocardiogram show us we can see negative T value in leads of V3 to V6, and the difference ST segment in leads of 1 and AVL. Next. This is the angiography about on May 12th, and we can see from the angiography imaging the severe stenosis at distal left main and proximal to middle of left anterior descending with severe calcification. Next. Okay, next. You can see severe calcification. Yes, next. And we evaluate the flow function, and you can see the QFR value is 0.23 after visual stand, and the QFR value increased to 0.97. Next. This is a right coronary artery angiography, and you can see a little bit about 40% stenosis, proximal RCA, and the QFR value is 0.84, so no need to treat. That's all. Thank you.
Okay, Dr. Dong already introduced the baseline information of the patient, and we already know that for the patient is a triple vessel disease patient, and the RC also with mild to moderate lesion in the proximal portion. The QFR value is 0.84. So this time the target vessel should be the left coronary artery. And we can see that patient is RC dominant vessel. So the RC is very large and the circuit is relatively small. And Dr. Dong already introduced the left coronary artery bifurcation with severe stenosis and with severe calcification. And as we know, the angiogram to detect the calcium is inferior to the CT angiography. So for this patient, we did the CT angiography and do 3D reconstruction. Let's see the 3D reconstruction of this patient's left coronary artery. We already use this intelligent visualization system for several times, show the audience how to use this system. And this is the left coronary artery of this patient. We can see the green one is the circ, and the light blue one is the LAD, and the white one is the calcified plaque, and the brown one is the soft plaque. And we can see it's just at the left main bifurcation area, there is a large calcified plaque just at the left main bifurcation. But at the ostium of the circ, a little bit soft plaque and a little bit calcified plaque. Next. And this is the spine view. We can better see the distribution of the calcified plaque. We can see the calcified plaque mainly in the left main bifurcation, the proximal LAD, but at the bifurcation of the diagonal branch, no much calcified lesion and a little bit distal to the diagonal branch. Next. And this is the epicranial view. We can see, strictly speaking, in the proximal portion of the LAD, the CTA reconstruction really could give us more information. At the proximal portion of the LAD, the true lumen, the LAD lumen, and between the LAD lumen and the calcified lesion, there is soft plaque. That means in this place should be deep calcification. Yeah. Next. We can enlarge the picture, zoom in, we can more clearly see the distribution of the calcified lesion. And this time we delete the brown soft tissue. We can see clearly the distribution of the calcified lesion at the left main and the calcified lesion and a little bit protrude to the ostium of the circ. And after we delete the brown soft tissue, we can see in the proximal LAD should be deep calcification, But when we go further distal to the LAD, we can see there is relatively large calcified plaque embrace the proximal LAD. So in that place should be what we should be pay more attention to. Next. This is two picture. The left one with the soft tissue and the right one deleted the soft tissue. We can clearly see the distribution of the calcified lesion in the proximal LAD, very clear. And in the ostium, deep calcification, but go a little bit further. So the calcified lesion embrace. So I guess the angle should be about 270 maybe to so closely embrace the proximal LAD lumen. Next. Okay, this time we delete the light blue LAD. We can see the distribution of the calcified plaque clearly, and we also could see the video of the live demonstration of the 3D construction imaging.
Next one.
Next. Okay. Dr. Wang, please show us a 3D reconstruction. Okay. The live demo of the 3D reconstruction imaging. So really, we can see this is the whole system.
Yes.
Yeah. The aorta is right. We could delete the aorta first. Delete the aorta, please, and delete the calcium plaque in the aortic wall. Delete the RCA. Delete all. And we can see clearly the distribution of the calcified lesion in the RCA and the soft plaque. And we could zoom in the LAD. Yeah, very clearly to see. We could rotate in any angle view. Okay, yes. We could rotate a little bit. Okay, other angle, please. Other angle, please. Okay, I think we should see the side view or the epicranial. Okay, show us. Okay, a little bit should be the side view to see the distribution of the calcified lesion, and we can see just as a diagonal bifurcation, no severe calcification.
Yes.
But go a little bit further, there is a calcified lesion. Yeah. Okay. So we could delete the brown one, the brown soft tissue, please. Okay. Okay, we can see the distribution. Rotate a little bit. Let's see the epicrinal view to see the most important part in the proximal LED. Okay, enlarge the picture. Zoom in, please. Okay, okay, zoom a little bit more. Okay, zoom. Okay, we can see. Zoom in. Okay. Okay. Dr. Wang, please. Okay, that's good. We can see in the optimal LED, deep should be deep calcification, but a little bit distal, there is a huge calcified plaque embrace
Yes.
the LED lumen. So the information I think is very important. Okay, let's see today's Andrew. And this time we choose okay the okay the right femoral approach.
Yes.
And here is still a small tips and tricks last time already showed to the audience, because we can see the aorta of the abdominal aorta also with severe calcification, and
yes.
the guiding was a little bit difficult to advance further, and there should be a calcified plaque. If we forceful to advance, even we rotate, the guiding still couldn't cross. And this time we use balloon assist tracking technique. Last time I already showed to the audience a workhorse wire and 2.0 balloon inflated at the tip of the guiding to mimic the CHD's guiding. And the guiding could be easily advanced. And we do coronary angiogram this time, and we can see the RC is no problem, and just like last time. And this is this time left coronary artery we use Jackins left 4.07 French guiding. And we can see from the angio severe calcification in the bifurcation, and the circ is relatively small, and the ostium of the circ relative normal. Okay, this is the spider view of the circ with left main should be about right angle, and we can see severe calcified lesion in the ostium of the LED. This is the RU cranial view, diffuse, very diffuse lesion. But the virtual standing technique already show us if we implant maybe 3 stents from the middle portion of the LED to the left main, the residual FFR maybe 0.997. So should be good enough. So the virtual standing technique also give us more guidance how to implant the stent. And because we already know from the CT 3D reconstruction, there is calcified lesion at the ostium of the distal left main. So the ostium of the circuit is relatively normal. So we prefer to choose one stent strategy. So in order to better debugging the left main calcified lesion, and we choose active Rota technique. Yeah. So as we know, also IVL today's key point is IVL, but compared with IVL, Rota could better debugging, reduce the plaque burden of the left main calcified lesion. So we may have more chance to choose one stent strategy, and this time we use 1.5 burr. We already use 1.5 burr to do the rota, and we use common microcatheter to exchange the rota wire, and this is what we often used technique, and this is 1.5 burr, and after several times rota, we can see several times rotablation, and we did intravascular imaging test. And that time we use the panel vision system. So this system is integrated both IVUS and the OCT. So for that kind of case, let's see if this system could give us more useful information. And the next, please like Dr. Chao to introduce the panel vision system, the result of the patient.
Okay, thank you, Dr. Li. And for me, this is a very interesting case because this is a typical left mean bifurcation with a very severe calcified case. And just like the demonstration by Dr. Li, that we checked that there is a very severe calcified plaque at the distal left mean and also at the trunk of the bifurcation. Here, I'm demonstrating this hybrid system of IVUS and OCT. Actually, this is a fantastic demonstration, I think, that for some very complex plaque structures like the calcified plaque and also the vulnerable plaque, sometimes that the OCT image and also the IVUS image can give some very haziness and hard to tell whether it's a calcified plaque or it's, for example, TIGFA or something. But with the help of this hybrid system, we can easily tell the details of these plaques. And from this run is from the proximal RAD to the left main trunk. At the mid part of RAD, we can see that the vessel diameter is relatively 2.5 to 2.6 millimeter. And on the right side is the IVUS image. We can see that in the comparison of these two images, we can see some very severe eccentric and also high plaque burden plaque. As the pullback comes to the proximal part of RAD, we can see some calcification, some superficial, some deep calcification in combination. And then we can see that IVUS image is of high sensitivity to the calcified plaque. On the image, we can see some high bright sparkles here. And also on the right side, we can tell the detailed information of the calcified plaque. There is a very sharp border of the black and calcified plaque. And also with pulling back, we can see that this calcified plaque is relatively deep and also the thickness is relatively big. As a pulling back from the proximal part of RAD, we can see some calcified plaque with similar to the circumferential. And also on the right side, we can see we can measure the angle of the calcified plaque. And also the lumen area, we can see after the rotablation, there is some lumen gain. Let's check the calcified plaque on the right side. It's 170. And also on the left side, we can see with the help of the OCT image, we can see the calcium is embracing the whole vessel. Let's come to the proximal part of RAD. You can see also there is some over 270 degrees superficial calcification, and also some deep, very thick calcium at the proximal part of RAD. The thickness is around 1 millimeter, which is relatively very thick and eccentric calcified plaque. And also, if we check very closely at the bifurcation site of the left mean, we can see that at the left mean, on the contrary side of the circumflex ostium, there is some superficial calcification. And also this kind of superficial might some influence the stent expansion and also cause some carina shift to the other side. So this is the general idea of the pullback from distal RAD to the left mean. We can see some very thick, eccentric, calcified plaque at the deep side. Okay, Professor Li, this is a hybrid system pullback of OCT and IVUS. We can see some thick and also deep and superficial calcification embracing the whole vessel, especially that at the ostium of the circumflex on the contour side.
Okay, Dr. Chao already introduced the panel vision system. This is also a domestic system. So integrate both advantages of the IVUS and the OCT. So Dr. already introduced the result of the intravascular imaging. And the result just similar to the 3D reconstruction just now. Doctor asked the system to tell the truth. The system we already showed in the 360 mass stream for several times. So the system is very useful, especially for the CTO PCI, and I will show the system in the future demo about how to use in CTO PCI. And for the that kind of chip PCI calcified lesion, so also the vessel also very useful, would give us very clearly demonstration the distribution of the calcified lesion, the relationship between the calcified lesion and the lumen and the soft tissue. So this is a AI technique based on the CTA 3D reconstruction and artificial intelligence visualization. And we already know in the proximal portion, just before the diagonal branch, there is a very large calcified burden, more than 370 degree. So I will use shock wave to try to fracture the calcified lesion. And because another difficulty for this case is for this patient with many set branch, the diagonal branch, the septal branch, and the circ, we have to try to protect all these set branch after stent implantation. That is what we do next. So at present, I try to wear the septal branch and then do the shock wave.
Okay.
Yeah. Dr. Chao could introduce more about the Chinese 3D reconstruction system to the
Okay.
audience. Okay.
Okay. Actually,
a little
that for me, that this case is quite interesting because first thing, just like Professor Lee introduced, this is a multiple bifurcation case. If you pay more attention to the angiography of this case, you may notice that this is only isolate septal and also only one isolated big diagonal. So we can see that this septal and diagonal is of key importance to the
Andrew.
heart function and also the prognosis of the patients. So like Professor Lee introduced, the whole idea of this procedure is not just maintaining the expansion of the stent, but also maintaining all the big branches to make sure the prognosis of the patients. And also, why do we perform active rotablation on this patient? If you see closely, you may notice that there is a relatively big and eccentric calcification at the bifurcation site of the left main. If we are using the traditional balloon-based plaque modification strategies, there is a of high likely and the chance to cause severe dissections, which cause the intima or hematoma at the left main bifurcation site. However, with the help of the debulking techniques of rotablation, to use the rotablation to reduce the plaque burden and also the plaque volume at the trunk of the left main bifurcation is of great importance in this case, because we need to treat the distal LVD lesion first. If we use a balloon-based plaque modification strategies, there is a high likely and potential risk to cause the big dissection and plaque shift to the circumflex, which is not, friendly for the following procedures. So this is why we perform the active rotablation first. This is relatively, we can see that so far the fluid is good. And also we check the pullback with a hybrid OCT and IVUS system to check that there is no, severe dissections, and also the flow is good. So the following procedures is that we can see with the help of the CTA 3D reconstruction software, which is a domestic software made in 100% in China.
Already where all these set branch, the diagonal, the septal, the circ, and we already know where is the severe calcified lesion distribution just before the diagonal branch. And now I will use a 3-0 shockwave balloon to fracture the calcified lesion. But the key point is if the balloon could be advanced to the target lesion. Yeah.
I think with the help of the 1.5 Burr rotablation, I think it will offer some benefit to the crossing of the folding
Okay.
devices. Yes, we can see that we pass very smoothly.
Oh. So the balloon was inflated at full atmosphere, and we will, okay. Alrighty. Okay. Okay. 6 days. Okay, done. So the first 10 bursts. Okay, test a little bit. We must be careful the pressure, please. Okay. Okay.
I think one key advantage of the lithotripsy system is that it doesn't spend a relatively long time or block the whole vessel for a relatively long time for distal myocardial ischemia or cause any severe chest pain or other symptom, which is relatively friendly for the patient, especially for some very severe left main calcification that we do not worry too much about the blood flow.
Okay. So
actually, in this case, with the help of the OCT and IVUS, we detect some very deep 270 degrees calcification, and also the thickness is really, severe. We can see that the average thickness of the eccentric calcification is 500 0.5 millimeter to 1 millimeter, so which cannot be solved by the traditional rotablation system. So I think in this case, to avoid the carina and plaque shift of the left main trunk, and also guarantee the stent expansion, the IVL system is of key importance in this patient. And later, after the lithotripsy, we can make another run of the IVUS to check whether this superficial and eccentric deep calcification has been cracked or not.
We withdraw a little bit. Inflation. Sometimes we can see the premature beats.
Yes.
Caused by the pars. Okay, 6 please. Down, please. Okay. Test a little bit. We already use 50 pars.
Okay, fell wrong.
Okay. Oh.
It is highly recommended to use the intravascular imaging system, no matter it's OCT or IVUS, before the treatment of severely calcified lesions. Because contemporary guidelines have different recommendations about the choice. For example, for the debulking or modification strategies for the calcified plaque. However, different kind of distribution and also the composition of the plaque may lead to the different prognosis and also the modification strategies. In this case, actually, I think that we have multiple imaging system to help us to get a better idea of the plaque composition and distribution. Before we touch the patient, I think in this case, the 3D reconstruction, the intelligent visualization system helps us to give some detailed information with a very direct view to see the composition and also the calcified plaque distribution. Okay, I think that Professor Lee has finished the first round of the lithotripsy, and we can see the flow. The instant lumen gain is relatively good.
Okay, so the cell branch still patented.
Yes,
especially we should pay attention to the septal branch. Okay.
So So I think this is a benefit of the lithotripsy. It doesn't cost too much time of the blood flow stop, and also there is no severe angina.
For the left main, please.
Okay.
So for the left main, I like to use a little bit larger shockwave balloon 3.5. Okay.
I think this makes sense because from the imaging system we checked, like I said, on the contrary side of the circumflex osseum, there is a very typical and very severe superficial calcification with the angle around 270. So this is really helpful in the later expansion of the stent, and also the reduce the risk of the carina shift. And also, when we are using the intravascular lithotripsy, we recommend to use 1-to-1 ratio according to the vessel size to gain the best effect of the lithotripsy.
So really,
shatter.
the 3D reconstruction system would give us more information because both the IVUS and the OCT couldn't give us a fully imaging of the distribution of the calcified lesion and
3D.
the relationship between the calcified lesion, soft plaque, and the lumen, and the angle of the set branch. And sometimes you also could see the collateral channel, and if the collateral channel is large enough, we also could see the collateral channel the distribution, and could give us more information, help us to make the optimal strategy for this for the patients. Because like in this case, the ostium LED should be deep calcification. So what the shock wave should be performed most should be at the like a little bit distal to the ostium of the LED, and in that place there is the panel vision system already show us like 270 degree calcification embrace the LED. So there should be.
I think this is the advantage of our system, that it gives you a very direct whole idea of the plaque distribution and also the severity of the disease. Intravascular imaging is good. However, it cannot give you a very whole idea, the whole view of the whole vessels and also the disease. This is, I think, the advantage of the 3D reconstruction system of the CTA.
But certainly, the IVUS and the OCT is of great importance. And what we need is multi-modal imaging system to help us. Okay.
And our audience online just showed great interest in our software. I think that in the following demonstration, we can make some better, explanation and demonstration of this software. And we can see that Professor Lee is choosing a different size of the IVL system for the proximal part and also the left main trunk to make the therapy of the deep 270 degrees of calcification. Someone may be, interested what situation and what kind of cases is suitable for the IVL system. There are several indications for the lithotripsy usage in the calcification. First one, I think that compares to the different plaque modification system, IVL is suitable for deep calcification and calcified nodules, especially like in this case, at the opposite side of the circumflex ostium, there is a very typical, 270 degrees superficial SIP calcification. And the second one is like in this case, relatively large vessels. We know that if the vessel diameter is over 3.5 millimeter, rotablation system without the beneficial of the wire bias, it is of less likely to perform debulking techniques for relatively big vessels. However, in this case, we can use lithotripsy for left main bifurcations. So it's suitable for relatively large vessels.
Okay, I think we should make an angel.
Hmm.
Give some natural, please.
I think we have finished the 3.5
Okay.
IVL system, and let's check what's the
So,
instant lumen gain.
in that case, we will show the audience the IVI system for the left main.
Left main, yes.
Yeah. So even for the left main, is relatively cheap and effective. And another key point we should talk about is for the circular calcification,
Yes.
for the eccentric
Hmm.
calcification, the efficacy of the IVR system.
Hmm.
So a study already showed. So for the circular calcification, the IVR system may cause more fractures.
Hmm.
Yeah. But the final results for the eccentric and the circular calcification,
Okay, I think
no,
the
no
yes,
significant difference.
yes,
Okay.
I think the instant lumen gain is very
Okay.
typical. This is a great demonstration in comparison with the rotablation system.
Okay.
You can see after the 3.5 IVL system, there is a very typical instant lumen gain. Flow is good. There is no severe dissection, and also we can see that it is very, successful balloon angioplasty. Someone argues about the IVL system usage in the left main. They complains or worries about, for example, the shock wave energy transformation. How to say, usage of a greater distance that the wave front needs to travel into the larger caliber of left main trunk. But I do not worry about this one. Just like in this case, we can see that later we may check the IVI system to check the fracture of the calcium. So we can see the IVL system usage in the left main is relatively safe and also effective. We know the PTCA system can, host to 60 seconds in the left main, and also the non-left main disease, respectively, without any signs of increased harm to the patient. When talking about the mechanism of the IVL system, someone may, worry about the risk of potential dissections, hematoma, and myocardial infarctions caused by this huge balloon. So, like I said, that there is a relatively very low incidence. It's like 0.4, percent of flow limiting dissections and other this advantage of the IVL system. Now we are checking again the IVUS from the LED to the left main to check the instant result of the IVL system.
And this time I dislike to use OCT model because we already use IVR system. Also, in most conditions, no severe dissection, but should be some dissection. And the forceful injection of the
Flush.
contrast may cause enlargement of the hematoma. And this time, just use IVUS, please. Okay, you can go on.
Okay, pulling back. Now we are pulling back from the mid LED to the left main. We can see that although the distal landing zone is not so clean, I think this is a potential landing zone. The vessel size is around 275 something. There is some very great eccentric, high plaque burden, superficial calcified plaque. Later, we may measure the angle of the superficial calcification. I think the great point of the IVUS in detecting the calcification is of a great sensitivity. This is the coming inside, joining into the main vessel is the diagonal branch. We can see there is a long diffused high plaque burden. I think the plaque burden, the average is over 60 or something. Very, okay. I think we can see some crack already.
Yeah.
Yes.
Several crack.
Actually, there is a pullback before the IVL system post the rotablation. I think later we may compare these two images to check the crack caused by the IVL system. And also the deep calcification, we can see that the IVL system can cause some great fractures. And also we can see this is a calcification on the contrary side of the circumflex. Later we may check its fracture. We are going to the left main. And I think that the first one should be 2005. Later we may measure the length. Okay, let me stop.
Okay.
Let's check again the fracture of the calcification, which we care about most. Okay, here we can see that this is, I think, a very typical fracture of the superficial calcification. And also this site is the most severe site of the calcification, just like demonstration of our intelligent, 3D reconstruction system. This is the
2.75,
proximal part of
13.5.
the LAD. And we can see this is a very typical, superficial calcification on the surface. And
And
here
1.5
is
balloon.
another demonstration of the calcium fracture. We come back proximal part here. Here it seems doesn't cause a great fracture, but we do not worry too much about this one because it's relatively not, too great angulation.
Just a little bit.
We come to the proximal part here. I think this is another fracture with instant, superficial calcification. And also, if you pay more attention, I think this calcification is relatively impossible to be, solved by the rotablation system. But with the help of IVL system, this kind of a penetration of the ultrasound, we can see there is a very typical fracture of the superficial calcification. We come to the proximal part of the LAD and distal left main here. I think this is another
We should
fracture
check
of the
the
calcium.
imaging of the diagonal branch.
Okay, now after the IVL system, we check the calcium. We can see several, fractures, not only the superficial, but also the deep calcification by the IVUS system. However, we can see that on the contrary side of the circumflex, this calcification doesn't seem to be a very typical. Oh, no. I think that there is also very typical, fracture on the contrary side here, this part. Before, let's check the imaging before the IVL system. It's a very, typical superficial calcification. After the IVL system, there is a superficial, fracture. I think this is good guarantee for the stent expansion.
Okay, Dr. Chao, we already this imaging system to the diagonal branch and use IVUS model to check the ostium the diagonal branch, please.
Okay, let's check the.
Help us to make sure if the diagonal branch
Yes.
ostium should
Mhm.
use geo balloon technique or just the geo balloon in the septal branch. Okay,
Okay,
IVUS, please.
Okay, put him back, please. This is a pullback from the diagonal branch. The whole idea of this run is to check the ostium of the diagonal. Okay, there is some plaque, I think, at the ostium of the diagonal, but I think that we needed to put a wire or a balloon to protect.
Okay.
Okay.
So that means
Mhm.
wire protection is enough.
Mhm.
No need geo balloon technique.
I think.
Plaque in the ostium of the diagonal branch, the burden is not very high and the lesion is relatively short. So this is another very important information. Okay, check again for the circ. Okay, apicaudal. Apicaudal.
Okay.
Check the ostium of the circ, please. Okay.
Okay, let's check this circ. And also there is some interactor from the audience. They wonder whether we are going to perform the DK crush for this spin. I think that we are planning to do a provisional stenting directly from RAD to the left main. And also we are checking the ostium of the circ to make sure that after the crossover stent strategies, there is, no other problem. So let's check the ostium of the circ before we make the strategies. And also from the angiography and also the CT image, we can see that there is almost no plaque at
Okay,
the.
Dr. Chao, you can.
Okay,
Yes,
pull back.
Okay.
This is a pullback from the circ to the left min. Okay, we can see
Okay.
the wire is it's joining. Let me check in the details. I think there is almost no plug.
So just similar to the 3D reconstruction.
Yes.
The 3D reconstruction
here.
already show us the distribution, just a little bit soft plug and a little bit calcified plug at the ostium of the circ. So certainly, I think for this case, we prefer one stand strategy.
Yes, and also we can see that the ostium of the circ, the lumen area is over 10 millimeter square. So we do not worry too much currently about the two-stand strategy. So like Professor Lee introduced, we are highly likely to perform an one-stand strategy with a provisional strategy.
Intravascular imaging already showed for the diagonal branch and the circ, maybe no need the gel balloon technique. But
So
I will put a small balloon in the septal branch.
okay.
So we must pay attention to the septal branch.
Yes,
So
and
also
also
the septal branch look like not very large, but the function is very important. Yeah, 1.5 balloon, please.
and also I think that the diagonal, the angle is relatively friendly. So if we need to rewire the diagonal, I think it's relatively easier compared to the septal.
Yeah, but the diagonal branch, the ostium is a little bit difficult to wiring. So we will try our best to protect. And certainly, let's see the result. If you could protect the septal branch. Okay.
And there is a question from the audience. He wonders whether this 3D AI, system is going to be a key information factor for the future, complex PCI procedure. I think
so.
Yes.
Our team invents the system. I think it's very useful.
Yes.
We already showed several cases in the demonstration. So the more complicated the lesion, the
more
more
information,
information the
we can
3D
acquire.
construction system could give us.
And also, I think that the how to say the advantage of this system is that it can gives you a lot of detailed information before you touch the patient.
You could talk about the gel balloon technique. Test a little bit.
So we can see that there is, multiple bifurcation cases. We need to protect the diagonal, the septal, and also the circumflex. And for the bifurcation PCIs, I think the most, how to say that situation that we need to worry is the maintenance and also the patency of the big set branches.
Test a little bit.
There are several techniques that we can use to avoid the compromise of the set branches after the mean vessel stand crossover. And also, for example, we can drill a wire, drill a balloon, and also drill an microcatheter, etc., like the different operator can use. However, all these techniques, I think that they have one, similar general idea, is to use a device, either it's a balloon, it's a wire, or it's a microcatheter, to occupy the space to avoid the carina shift of the bifurcation site. So I think that whether you're drilling a wire or a balloon or any other devices, I think this one depends on the detailed information of the bifurcation. From yes, a little bit further, maybe think.
Okay.
1.5 millimeter, I think.
Okay.
Yes.
I think here is okay enough.
There is a one
Andrew?
relatively.
Okay.
How about the Jillian balloon a little bit further?
Yeah.
So like we talked, whether either you are drilling a balloon or wire or microcatheter, the whole idea is to use the device to occupy the space to avoid the carina shift during the expansion of the main vessel stand. So we can see that using this gelled balloon techniques, it can reduce the risk of carina shift.
5.
And also we can see that if you are
1.5 below.
opening the geode balloon
Okay.
at the same time of opening the stent,
1.
like this one, professor is
2.
demonstrating. It's like
3.
the performing and casing with a geode balloon and also an stent. It can
7.
maintain the carina in the middle part of the bifurcation site, especially the POC area.
9.
This is of great help because some relatively small caliber, bifurcations, it's hard to perform some lateral casing, procedures because the side holes
Test
of
a
this
little bit.
main vessel stent is relatively small. It makes you
Okay.
hard
The
to
stent
revere and also
inflate.
pass through
No,
a
no, no, this one.
second
This
casing balloon.
Yeah.
So I think that we can see that professor is performing an
8.
SKB techniques
Nine.
to maintain the big relatively septals. And
Okay.
also, I want to emphasize, in this case, we need to pay very great attention to the big diagonals because no matter its size and also the length is really big. So it's performing in a relatively
Okay.
big area of the myocardium. And also there is some concentric plaque at the osseum of the diagonal. And the minimum lumen area of the diagonal we just check is 2.1 millimeter square. So we need to pay more attention to that diagonal too, because this is an isolated diagonal of this patient, so it's of key importance. Professor Lee has just released the first stent and covered the osseum of the septal and the diagonal at the same time. I think this is a good choice because if we are only covering one stent branches, it is relatively difficult to solve the keep the opening of the other ones.
Test a little bit. Test. Okay. So I think the set branch balloon should be inflated again.
Mm-hmm.
Maybe. So really, there are many types of gel balloon technique, but I prefer to use this one. Okay, inflate.
Yes.
6. Okay, done.
Some operators try to use the body of the balloon as a jailing devices. Someone uses connecting catheters of the balloon as a jailing devices. But the professor is using, we can see that 1.5 balloon and performing the SKB techniques to maintain the carina shift. Actually, there is a question from the audience wondering, is there any additional complications or risks associated with the procedure, and how can we manage? Actually, if you pay more attention to the whole, idea and procedures, how Professor Lee demonstrated, we can see that in this case, there are several things. First, it's a multiple bifurcation case. We need to maintain the opening of the side branches and especially the circumflex. So why we are performing the active rotablation, which means that we are performing the rotablation first. You can see we didn't use the balloon and the cutting balloon or NSE balloon to perform the balloon first because we want to try our best to avoid any potential dissections and hematomas. In this case, because this is a multiple bifurcation case, we need to use relative some time and energy to treat the distal LVD and the septal bifurcation site. So active rotablation can reduce the risk of potential dissections and hematomas in this case, which gives us time and the energy to solve the distal, calcified lesion and also the bifurcation site. So I think that active rotablation as the first time in this case is a good choice. It can avoid some potential, complications. And also the other things is that there is some very severe superficial, eccentric calcification. So we know that the biggest problem of superficial and also eccentric calcification is restriction to the stent expansion. We know that the former OCT studies demonstrated without any intravascular imaging system, the stent expansion ratio is only around 60% or 70%, which is relatively low. So we can see that with the help of all these imaging devices, we know the distribution and also the severity of the calcification. So we choose wisely which kind of modification strategies to use. After the rotablation, we use the IVUS to detect some very deep and very thick and calcification, especially at the left main trunk and the proximal diagonal. So we are choosing the IVL as a second strategies to treat all these kind of big calcifications. You can imagine when we are using some, big balloons to do the sequential balloon
we can see
dilation,
both septal branch and
it's
diagonal
maintained.
branch is patency.
Yes.
So why we didn't use pre-dilation balloon to dilate? Because I think we already use the IVL system,
Yes.
the standard cross. Okay, and okay, just like okay, post dilation balloon, please.
The audience wonders the how to say the necessary and the importance of this wire in the septal. I think that this is of great importance for this patient because you can see that it is almost an isolated septal. There is one big and isolated septal because of keeping its patency is of great importance. Sometimes this size of septal, the loose of this size of septal can also in fact, influence the heart function of the patient and also not to mention the angina after the procedure. So we continue with the topic that we just talked about. There are several potential risks to lose the side branches, big hematomas and dissections. And also, I think in this case, the other risk is to transform one strategy to a two-stand strategy. If you are using a scoring balloon on a very big balloon to make the dilation at the bifurcation site of the left main trunk, there is a high likely to cause some plaque, distribution and to the circumflex ostium or some minor dissections to the ostium of the circ, which is relatively difficult for the folding procedures. The combination usage of rotablation and lithotripsy has been reported in several manuscripts. However, we want to emphasize that it is not a recommendation to the routine use of combination of rota and lithotripsy. In this case, why we are using the rota and the lithotripsy at the same time, as I just explained, is to use the rotablation to make a guarantee for the transformation of the potential devices, and also that we want to avoid any potential dissections and hematomas.
Okay, let's check IVUS again.
Okay.
We've already implanted the first stent.
Now let's check again.
And all the large set branch
has been maintained.
patency.
Yes. Please flash again, please. So this run, we can check the first stent, its expansion, its location, the distal landing zone, and also we can check the folding, the second slant, to measure the length and the diameter of the second stent to make the folding procedures.
Okay, you can check.
Professor Dong, could you flash again, please? Okay, I'm pulling. Okay, thank you. I'm pulling back. You can see that we are coming proximal to the distal edge of the stent. I think, Professor, you just landed on the perfect landing zone. The landing zone is perfect. There is no dissection. There is no hematoma at the distal edge of the stent. However, I think we require some relatively, good post-dilation of the stent because it's not so much well expanded yet compared to the distal landing zone. And according to the consensus of the stent expansion, that we require over 85%, at least 90% of the stent expansion compared to the distal, reference vessel segment. Here is a superficial, eccentric calcification segment. There is some, stent under expansion, we need to do some post dilation first. I think the plaque has been modified. I think that all these instant lumen gain is relatively good, and we can see some fractures as the superficial very thick calcification. We are coming into the left min already. Okay, let me stop.
So give some suggestion about the second stent,
Okay.
the length and the diameter.
Okay, first thing, like I said, that we might need to perform some post dilation later for the first stent, maybe a 275 NC balloon, and also for the second stent, if we connect it to the first stent for 2 to 3 millimeter, let me see, I think here might be long enough. Okay, this is the circ coming inside. About 30 to 33 with the diameter, let me check, maybe a 30, I think is enough. Okay, how about 33 by 30 stand? However, I think that we can use a cutting balloon as a distal left wing bifurcation trunk to do some plaque modification, because we can see, although after the IVL system there is some very good instant lumen gain. However, I think that some the plaque modification still is necessary in this case.
So 3O cutting balloon, please, and to debugging the left main calcified lesion again. And for me, I prefer to use 2 stents.
Yes.
Yeah.
Okay.
For the proximal LED, I use
Okay.
0.
Okay.
And the left main use 3.5.
Okay. Sure.
So we must be careful the overlap of the with the distal stent not cover the ostium of the septal branch.
Okay. Okay.
So try to avoid 2 layers of stent at the ostium of the
Yes.
septal branch. Okay. Ricardo, please.
So if so, we are using the 3.0 stent in the LED and the 3.5 stent into the left main. If so, I think the first one is around 20 millimeter is enough. The first one to the near the ostium of the LED. I think the first one is around 20 is enough.
So 3.0, 20, please.
Yes, 3.0, 20, 22 is fine. Three o 22.
Okay, inflation, please. Slowly a little bit. 6, 8, and
So like Professor Lee just
down.
explained, in this case, the combination usage of rotablation and ABL system is relatively representative. One thing is that in the big vessels and the very great eccentric superficial thick calcification, it's relatively very hard to be debulked using the rotablation system. And no matter whether the wear bias is good or not, I mean, there is a little chance to solve a very superficial, eccentric, thick calcification with the rotablation system. So yes, to answer the questions of the audience online, the IVL system usage in this patient on the distal left main bifurcation has reduced the risk of, falling 1.75 burr or 2 millimeter burr usage to reduce the risk of rotablation in this case. So this is the advantage of IVL system in this case.
Yeah, you in most conditions. So when we do through lithotripsy strategy, 1.5 burr is large enough.
Yes.
But we must know the purpose of the rota. If we need to debugging more calcified lesions, we still need a larger burr to debugging the calcified lesion. So for that case, certainly we also could choose larger burr to debugging the ostium calcified lesion. Yeah, but the intravascular imaging showed already good enough.
Yes. not necessary. It's not
Not
necessary to use a bigger bird to cause more risk. And also there is one thing I think that need to
Epicranial,
for worth
please.
mentioning.
Are
The incidence of side branch compromise, for example, occlusion or slow flow during the bifurcation provisional stenting, it's of great importance in the bifurcation PCIs, and also compares to the rotablation to the other debulking systems. The rotablation can reduce the risk of side branch loss compared to the non-rotablation group. I think this is how to say with the benefit of
we need to
the rotablation debulking strategies.
Okay, Epicardo, we need to put back all the wires still in the side
Yes.
branch.
Yes.
Okay. But before we install the wire, you test. I think a little bit longer. Okay. Okay.
Okay.
A little bit longer. We need a shorter one.
Okay.
Okay. Shorter 3-0 shorter balloon. Shorter stand, please.
This is a 20.
20? Oh,
Oh, okay.
23.
20 is fine. 20
sorry,
is fine.
Sorry.
In this case, we do not want this one to cover the distal
So I think
bifurcation.
18.
18 is fine.
18,
Yes.
18.
20.
To
Yes.
cross over the osteoid.
Yes. 20 is the connection part is 3 millimeter to the distal stand. So.
So I think it's time to want to.
Yes, I think that we are ready. Yes, switch to the second room. Yes.
Okay.
Actually, there is a lot of questions from the audience online. They are very interested in our case, especially our software, the demonstration of the 3D CTA angiography, and our combination usage of the rotablation and the lithotripsy. I think that the whole idea of this case is to introduce how we use the CT reconstruction to offer very key detailed information before we touch the patient to help us to make some very precise, plans for this patient.
3-5 short stand, please. 3-5 short stand. Do you have 3-5 short stand?
13, 12, something. 13, okay.
Okay. I think we need to withdraw a little bit. Okay. Install the diagonal wire first. This one should be the diagonal. Okay.
And also the second thing is that the combination usage of rotablation and lithotripsy. So in this case, I think that the rotablation is only for debulking to reduce the plaque burden and also the calcium volume to make some advantage for the later device. Transfer to go through the lesions. It's not using the rotablation to solve all the system of this patient. And also the LVL system, you may notice we use 2 balloons of the LVL system to fracture to debulk the different site of the deep calcifications. So this is our whole idea, very important information that always try to use 1-to-1 ratio IVL system to perform the shockwave functions, not to use only, for example, some operators try to use 4.0 IVL balloons to solve all the problem. I think this is not a good idea.
Yeah.
And also that this kind of combination usage can reduce some potential risk compared to the conventional balloon, modification therapy.
Andrew, please.
Okay, I think this is perfect. 18 is perfect.
Okay, Picardo.
Severe coronary artery calcification remains challenging during the PCI. Often requires one or more advanced calcium modification tools. The combination usage of rotablation and AVL
14.
can help us to better solve
14.
the problem of the calcifications.
16.
Okay, Professor Lee, I think that we are still online. They are all still with us. I think. Thank you. Okay.
Okay.
I want to thank the how to say the passion of the
Situation,
audience. Actually, there is another question from the audience. They wonder why we were not using the IABP system for this patient. First thing is that I want to explain this patient is a
35,
relatively
13.
young patient, and also the heart function is relatively normal. We can see that in the previous PCI, we solved the problem of the RCA. The RCA is normal, and the circumflex is not a dominant vessel. So this time we are solving the LVD and the left main. It is not an unprotected left main. So I think that with a normal function, yes, with the normal heart function that we also at least kind of the detailed information from the CT angiography and also this kind of full usage of the debulking strategies like the rotablation IVL, we can make a good modification of the plaque to maintain all the big set branches, to maintain the blood flows of the big vessels. So this is the whole idea, of this case. So I think that for now, for the current situation, IBP is not necessary. And also we can see that currently the situation of the patient is stable, the heart rate, the blood pressure is fine. So I think that for now, IBP is not necessary. However, I want to emphasize we have IBP in our room standby here. It's just at the corner of the room. So if there is some, unexpected situation happens, that we can use the IVP, very quick. So thank you for your question. This is a good question. Actually, our team consider the usage of the IVP possibilities in this patient, but we can see that currently it's fine. It's not necessary.
Go back a little bit.
I think another how to say
Okay.
the
Inflation, please.
how to say why we're not using is that we try to maintain all the big set branches.
14.
Like you see that we keep a
14.
wire and also a
16.
gelled balloon in the septals. We maintain the septals, the diagonals, and also the circumflex. So I think that it is a guarantee for the prognosis and also the instant
Test a little
situation of
bit.
the patient in the current case.
Test a little bit. Okay, here, test.
Someone worries
Inflation,
about
please.
the set branch loss
18.
of the calcified plaque because we see a
19.
lot of diagonal and, for
20.
example, the
Okay,
OM branch loss in the calcified plaque. The risk is 6 to 15% bifurcation loss during the calcified plaque. And however, with the help of rotablation and other debulking techniques to reduce the plaque burden,
Andrew,
also
please.
to try to maintain the sub branches.
Okay, we can see the left main
Yes.
application should be
Mhm.
okay.
Yes.
The circle is patterned
Mhm.
and
Mhm.
okay. So what we will do next to reveal the diagonal branch and the separate branch,
Mhm.
do post dilation,
Mhm.
to try to
Mhm.
make all the stems
Mhm.
well
Mhm.
expanded.
Mhm.
Okay, okay. Okay, another wire, please.
Actually, the whole idea of the rotablation and IVL system is to guarantee the stent expansion. Although we didn't check the IVUS after the second stent has been implanted, but we can see that stent expansion is relatively good.
Also, we could check.
Yes, the audience is very interested in our case. We are still online.
Okay, okay, let's check IVUS again. Okay. So this step is very important because when we advance another wire,
Yes.
simply we could use dual lumen catheter
Yes.
technique. If we don't use German catheter technique, sometimes if the left main stent not opposed to the left main vessel
Yes.
wall very
Yes.
well,
Mhm.
the wire may go outside of the stent
Yes.
between the vessel wall, and after we advance balloon
Mhm.
like
Mhm.
other apparatus may
Mhm.
cause a stent deformation.
Yes.
This is a complication we should try to avoid, but we still have some tips and tricks. Sometimes we make the workhorse wear to make like a U curl
Mhm.
to knuckle to
Mhm.
the
Yes.
stand, so to make sure the wire go inside the true
Mhm.
lumen of the stand
Mhm.
and then pull back to advance to
Mhm. Mhm.
to the
Yes, it
diagonal
is.
branch. And
Yes, it
certainly
is.
because this is a demo, so let's see
Okay.
the
Mhm.
stand. How about the stand auto, please?
Okay, let's check the IVUS image after. Okay, pull back. This is a IVUS image from the proximal LED to the left min. We can see this after the second stent expansion. We can see relatively the eccentricity is not so severe. However, I mean, we haven't performed NC balloon post dilation yet. So we can see that the stent is relatively need some more extension. I think the calcification is, I mean, not a problem anymore. We can see that the eccentricity of the stent is relatively good. Thank you. And also we can see the wire from the circumflex is joining into the main vessel. And also we can see that this is a relatively good demonstration. Okay, I think we are good. The wire is
So I think we could do part first.
okay, yes.
Use a relatively larger balloon. So any suggestion what size?
Let me check the stent size.
So 0.
Here is some malposition at the proximal edge of the stent. So I think maybe either an 325 at a relatively high pressure or 3.5 at a relatively low pressure is fine. You can see here is some manipulation of the stent.
Where?